Hi everyone. So thank you so much for signing up to our seminar today with Dr. Damon Thomas. Um, this seminar will be recorded, so if anyone has any issues, please do let us know immediately. If you have any questions during the seminar, please pop up in the chat box or please leave them until the end for the Q&A session. So Dr. Damon Thomas is a Melbourne-based, highly skilled plastic reconstructive surgeon with experience that spans more than a decade. He has expertise in pediatric and adult hand and microvascular surgery and all aspects of reconstructive nerve surgery. He is well versed in aesthetic surgery, including the enhancement and rejuvenation of the breast, face, and body. So over to you, Dr. Thomas.
Thank you for the introduction there, Sophia. So as already introduced, my name is Damon Thomas. I'm a plastic and reconstructive surgeon. So I'll go through my introduction shortly, but what we're talking about today is complex hand injuries and scarring, the two of which are often intertwined. I'm a plastic and reconstructive surgeon. I'm involved in quite a range of different conditions in terms of what I treat clinically and also what I treat from a medical legal point of view. Medical legal work, I'm a credentialed in AMA 4 and 5, so both 4 and 5 credentialing, and that's in upper extremity and skin and scarring. So see a lot of medical legal patients for reports and opinions with regards to hand and arm injuries or problems following work-related or motor vehicle accident-related conditions, and also skin and scarring. So skin and scarring can be by itself, for example, things like burns, or it is often combined with a hand or arm injury. Clinical background. So I do a combination of public and private work. Public appointments at the Royal Children's Hospital in Melbourne. So I'm a paediatric hand and microsurgeon at that institution. So that involves hand injuries, cancer work, congenital work with kids, brachial plexus palsy. Kids can be born with an injury to the arm from a nerve perspective, so I deal with those children on a regular basis, and general pediatrics as well. Do a lot of reconstructive microsurgery, so that involves again repairing traumatic wounds, reconstructing cancer defects, and general range of microsurgery. In addition to the Royal Children's, I do a lot of adult work as well, and have public appointments at Geelong Hospital, so Barwon Health, which is pediatric in part, but most of it's adult work in terms of injuries and reconstructive work, again to do with cancers. In addition to this, my private practice is based in Melbourne. I have quite a wide range of what I do. Again, hand and microsurgery makes up a significant portion of my work. Reconstructive surgery to do with injuries, general trauma, skin cancers. And in addition to that, I do a reasonable amount of cosmetic work. And this ranges from cosmetic body work, breast work, and facial surgery. So I'm well versed at the reconstructive side of the spectrum and also at the cosmetic side of things. Frequently get asked to comment on both reconstructive and cosmetic opinions in terms of best approach moving forwards, previous treatment that a patient's had, and I guess what should be done moving forwards. So I thought I'd highlight a few cases. These are my own patients which I've been involved with, and I'll run through two main ones to demonstrate a typical assessment. So today's discussion is, I guess, partly to do with an injury that's been sustained, but more to do with how do you assess it from a clinician and medical legal point of view. Hand replant essentially means a complete amputation of the hand, and replantation is the process of reattaching it. So there's a few steps that you go through when you deal with these conditions, and you've got to have a logical stepwise approach to how to successfully salvage these. These patients often come in with quite dirty or contaminated wounds, So it's really important to do what's called an adequate debridement. Debridement's a suitable term for essentially cleaning and removing any contaminated tissue. And the reason for this is to minimize the chance of infection. This is always done in an operating theatre. Sometimes you have two teams working simultaneously for these types of injuries, and it's just often combined with multiple specialties. This one may involve orthopedics, it may not, but amputations which are higher up the hand or arm would often be combined cases with orthopedic surgeons. So again, you have to have a logical stepwise approach to these, and you need bone stability first to make sure that skeleton is stable and make sure nothing is moving around before you do the finer soft tissue surgery. So in this sort of example, the patient's got what's called a amputation through the carpal bones, which are the wrist bones, and base of the metacarpals, which is the carpal metacarpal joint. It doesn't quite show the proximal or higher up part of the hand, but there's an amputation through the wrist, obviously. Often have to do what's called a bony shortening procedure, which is where you take out some bone on either side of the amputation. The reason for doing this is there's often contaminated tissue present, so you want to take it back to healthy tissue and bone. And also, when you shorten the skeleton, it actually helps to bring the soft tissues, which are tendon, nerves, and arteries and veins, back together, and that there's less distance for you to join them up. So that generally helps with your soft tissue work. So bone stabilization is the first thing to undertake. When an amputation's been sustained, blood supply to the tissue and hand in this case is critical. Important to get blood coming in, which is arterial inflow, and blood getting out, which is venous outflow. So if you don't have either of those, then the tissue is going to die. So these types of procedures, you have to do one minimum artery and one minimum vein. In reality, it's nice to do more than one. So for example, a hand at this level, which goes through the carpal bones, you'd ideally want to anastomose. Anastomose is joining a vessel in this sense. The radial and ulnar arteries. Radial is what you take your pulse with on the side of the wrist, and the ulnar arteries on the other side. So you'd normally do two arteries ideally, and then you do the veins, which tend to be over the back of the hand and wrist area. Again, ideally 2 or 3 veins stop. The reason for this is it just optimizes perfusion. Not much point having a hand unless there's sensation and movement. So the nerve reconstruction essentially involves joining nerves together, which is what's called a coaptation. So nerves have 2 functions. One is to provide movement, which supply the muscles. So the nerve supplies an electrical signal to the muscles, which thereby allows them to contract and thereby create movement and power. So that's the one function of nerves, which is motor supply or muscle innervation. The second main function of nerves is to provide sensation. So when you join a nerve at its point of division or laceration, you're aiming to restore some degree of movement if there's muscles beyond it, which in this case there will be, and also to provide some sensation. Now, when you join a nerve, unlike a blood vessel, when you join a blood vessel together, there's blood flow immediately, so that starts straight away. Nerve repair is different. The point of where a nerve is joined, which is the point of coaptation, actually requires long time for it to regenerate. It grows very slowly from the point of repair down to the end organs, which in this case are the muscle and the fingers providing sensation. And this can actually take quite a few months, even a year or 2, before you know what you're going to be left with at the end of the day. And nerve recovery will only ever be partial. You never get complete recovery unless it's a child. Adults, there's always deficits. Tendon reconstruction is also important. The muscles and tendons which bend the fingers and the thumb start up in the forearm, and therefore these need to be joined to allow movement. So the tendons which bend the fingers like that, tendons which straighten the fingers. So it's very important to repair all of those. There's 2 tendons to each of the fingers, index, middle, ring, and little fingers. And there's 2 tendons which bend each finger and joint. Nice to do 2 per finger. You could just do 1, which is the main one to the end joint. Also tendons which straighten the fingers, again over the back, and at the wrist level where this has come off, you only need to do 1 tendon to the middle and ring fingers. There's 2 each to the index, little, and thumb. So it'd be nice to do all of those tendons. There's also tendons over the back of the wrist, which provide stability, and in this case, they may or may not need to be repaired. The skin is the last thing to come together, and that's again important to get adequate closure so that everything's covered. You don't end up with wound issues. With these injuries where it's quite severe through a joint, sometimes you do what's called a fusion, where the actual bones are apparently stiffened, so there's no movement there. So if it's a significant injury through a joint or in that area, that can be required with regards to the bone stabilization. So there's 2 main components to assessment, with regards to what I see, and utilizing chapter 3, which is the upper extremity impairment. You go through a whole sequence of measurements to do with movement and sensation. So the page on screen on our left is the assessment of the fingers and thumb. So what you do is I tend to start with the thumb and then move across to the fingers. So what you're doing is looking at the ability, for example, the thumb to straighten, the thumb to bend. That's pretty better. Thumb to come across to the base of the little finger, which is called adduction. Thumb coming out by the side, called opposition, and also the web space. So those movements are key. So you've got 3 joints, interphalangeal joint of the thumb here, metacarpal phalangeal joint, and carpal metacarpal joint. So each of them have different movements. So that sort of examination, straightening, bending, across the base of the little finger, out from the palm, and web space relate to all 3 of those joints. Fingers, slightly different. The 3 joints are, I guess, more distal towards the fingertips. Metacarpal phalangeal joints here, which are cross through here. Proximal phalangeal joints here, distal interphalangeal joints. So when you measure these, there's 3 different measurements, which you do for each finger. So extension is where you're straightening the fingers like so, and you measure each joint individually, MCP joint, PIP joint, DIP joint. As you can tell on me, these joints, for example, normally go completely straight, whereas the MP joint through here tends to have a slight, what's called hyperextension, and the normal hyperextension for a hand is 20 degrees. Flexion or movement is the next thing to analyze. So again, you're analyzing 3 joints, 1, 2, 3, and measuring the amount of bend through the MP joint, PIP joint, and DIP joint. And just for an example, you use what's called a goniometer, which I'm sure you would know about, which is a device which you place over the back of each joint and measure the movement. So it varies from, as you know, 0 degrees, which is full straightening, to anywhere from up to 110 degrees, which you get from an MP joint. That's all documented in the notes in terms of the calculation sheet. Next thing you look at is the level of amputation. If there's an amputation, by that I mean, so for an index finger, at what point you've got a missing finger. So it can be right towards the end, further down, right at the base. So it varies from 0 amputation, which is the whole finger's there, to 100% amputation where the whole finger's missing. So that has significant relevance with regards to the assessment. Third column is the sensation. So what you do is measure the sensation on either side of the thumb or finger. There's 2 nerves on either side of any thumb or finger. So you measure one side, which in this case is the radial side towards the thumb. You also measure the ulnar side, which is the opposite. So 2 nerves run on either side of each finger and thumb, and one or both of those nerves can be compromised. And if that's the case, you lose feeling. You don't lose any movement or motor loss because the nerves which supply the muscles are well down towards the hand and wrist area. Once you get into the finger, the nerves only supply sensation. So there's 2 ways well, 2 different dimensions that you look at for 2-point discrimination. So 2-point discrimination is where a patient can feel 1 point on a thumb or index, or 2 points. So 2 points is where you're touching the skin with 2 points. So for this indication, paperclip here, so 1 point, they feel 1. 2 points, ideally they feel 2. However, if you're touching them with 2 points and they only feel 1, then that's abnormal. So there's what's called complete absence or partial absence of 2-point discrimination. If the distance between the 2 points is 6 millimeters, that's considered to be normal sensation, so they don't get any scores or impairment for that. If the distance between the 2 points is 15 millimeters and they can feel that, that means they've what's called partial sensory loss, because they've got 15 millimeters sensation but not 6. However, if they cannot feel the 2 points at 15 millimeters, then they've got complete loss of sensation. So I'll just summarize that. Measurements 6 millimeters apart for the 2 points. If that's present, that's normal. If it's absent, you then assess at 15 millimeters. If that's present, then the sensation loss is partial. If at 15 millimeters there's nothing, then that's complete sensory loss. So you score that on both ulnar and radial sides, which essentially is both sides of each finger and thumb. You then do calculations to come up with a combined digital impairment score, which looks at combining the abnormal motion, if there's any level of amputation, if there is any, and then sensory loss again, if there's any. You end up with combined value score for each digit, thumb, index, middle, ring, and little, and that converts into a combined digit impairment score, and then you convert it to a hand score. You combine all the hand scores together and then come up with an upper extremity impairment and then a whole person impairment from that. The second page on our right is looking at more wrist, elbow, shoulder assessments, and this is essentially again assessment of the movement. So for example, wrist movement, let's analyze extension, which is that, going backwards, flexion, which is down, and then what's called radial and ulnar deviation. Radial is that direction, ulnar is that direction. So you're assessing movement again with the goniometer. You can do the same for elbow in terms of straightening the elbow, bending the elbow, also putting the palm to the sky, palm down, and then shoulder movement. Shoulder's a complex joint, has lots of movement in all directions. So that's all assessed. There's a separate area to look at what's called peripheral nerve impairment, and that essentially looks at the main nerves in the arm, which are the radial, ulnar, and median nerves, and you look at a combination of injury to those, and there may be sensory loss, as loss of sensation, there may be motor loss, which is loss of movement, or there can be a combination. So you use a table with all the charts on that, and then you work out a peripheral impairment score. There's other modalities which I don't see a lot of in terms of my work, peripheral vascular system and other options to assess. So if you do have an injury which is not just the hand, then you tend to use both those tables. If it's just the hand, you only use the one on our left. But if it's the hand or something further up the arm, then you tend to use both. You could use the right one in isolation if the hand is uninjured. So you work out the values based on the the upper extremity impairment with regards to the hand, you combine that with the upper extremity impairment of the wrist, elbow, shoulder, and that provides a total upper extremity impairment. You may combine that with the peripheral nerve impairment if they've got any nerve damage, and that gives you a upper extremity impairment, which then converts to whole person impairment, again with appropriate tables. That's essentially a motor function and joint function with regards to movement, sensation, and any nerve range to do with motor movement, which is muscle movement. Second aspect of a lot of assessments, often combined with a hand or upper limb injury, such as a laceration, can be just a burn in isolation. Looks at impairment from a skin perspective. Essentially what it comes down to is assessing a patient with regards to whether they have any limitations of their activities of daily living from the disorder and or required treatment. So activities of daily living can be, it's a range of things, hand function, ability to drive, ability to feed and care for yourself, sleeping, sexual function. There's a whole multitude of things you look at. So some patients have no effect on their ADLs. Some have a minor amount and some have a major amount. Treatment is pretty variable. Can be anything from applying creams and moisturizers to sunscreen, to wearing a pressure garment where you have the area covered, wearing a glove for the hand, or creams or lotions, which might be something like a steroid, so more of a therapeutic assessment. There's a whole multitude of potential options there. And again, it can be not much at all to a moderate amount to a severe amount. So you end up with a class 1, 2, 3, 4, 5 based on that. Class 1 is the least severe and class 5 is the most severe. In my practice, tend to see almost all class 1s, so the minor area of severity, sometimes 2 and 3, 4 and 5 would be highly unusual. When you assess these patients, it's important for them to be stable. So by definition, based on the AMA 4th edition guidelines, they have to be stable for a period of greater than 6 months for you to do an assessment. Otherwise, obviously things may be changing, so you want to wait till they've plateaued. So we've talked about the upper extremity assessment, which is chapter 3, which we've gone through in detail. So range of motion, nerve injuries with sensory loss, motor loss, strength, movement, and then skin and scarring, which is chapter 13, which is essentially effect on activities of daily living and what treatment, if any, is required. So you get this, what's called a combined whole person impairment, which is pretty critical from a reporting point of view, because this is the essentially the end point for the assessment in terms of the maximum level of impairment. So you combine the upper extremity whole person impairment score with the skin and scarring impairment, whole person impairment. So again, using the tables and the calculations, you get a combined whole person impairment, which is the all-encompassing impairment for the hand or arm injury and associated scarring. Hopefully that's clear. So I'll show you a clinical case of mine. Patients given permission for the images to be shared with anyone involved from our education and also social media website perspective. So this guy unfortunately had essentially a work injury, high pressure injection injury to the thumb, which is the black area on our left. So what it's caused, is complete necrosis or death of the thumb print. So the whole part of his thumb over the area which you use as a thumbprint is gone essentially. So the skin's turned black. That's not viable. Black is obviously bad. In this case, it's not just the skin, it's actually the whole structures underneath. So if it's just skin only, you could potentially do a simple reconstruction. But in this case, because the skin is dead, the fat underneath is dead, then that's more of a complex issue. In this case, the bone and nail area are intact. If they were not intact, you'd probably just amputate it. But in this case, the bone and nail region is intact. So what we're trying to do here is reconstruct the thumbprint to provide sensation, to provide movement, to maintain length, and also for cosmetic reasons to make sure the thumb looks as good as possible. So this is quite a nifty operation, one of my favorites. It's what's called a toe pulp transfer. So that's his great toe or big toe on the left, the left foot on the right side of our screen. So what I've done there is dissect out the outside part of the great toe. So you take the skin, take the fat underneath, nerves which supply sensation when they're connected, and the blood supplies. It's critical. If you don't take this with what's called a vascularized blood supply, it'll die, it just won't work. So that's blood getting in with an artery, blood getting out with vein or veins. So hopefully you can see this. That's the skin there. The blood vessels are down through here, and the nerves are underneath, which you can't see. So that's transferred up to the thumb, and the what's called the donor site, which is where the flap comes from, generally has a skin graft to fill that in, just to close the defect. Sometimes you'll heal by itself, but more commonly a skin graft. So this is the end result, which if you look at it closely, you can see it, but it's actually quite hard to tell otherwise. So he's had a phenomenal result. Cosmesis is important, shouldn't discount how things look. It does affect patients significantly. So good looking thumb. It's got a pulp or thumbprint, and he actually did well from a sensation point of view. He got some 2-point discrimination back, and he was obviously very happy. His thumb was bending, straightening, and he got some feeling back in the thumb. So other options to reconstruct this aren't great. That's what he's had done there would be the, I guess, gold standard with regards to what can be done and achieved. So that's a nifty thing about plastic surgery. Reconstructive, you can do some pretty amazing things with moving tissue around. That's actually one of the reasons I went into plastics, or probably is the reason. Apart from that, he's going to need dressings for a little while, hand therapy to get things moving, and then it's just a matter of time. So as I said before, how long will it take before you know where you're going to be? Probably 6 to 12 even months, even 2 years sometimes. So from his assessment perspective, same as the previous principle, you're going to use the Upper Extremity Assessment, Chapter 3. In this case, it's almost certainly just going to be assessment of the thumb only. So that's going to be movement, so straightening, bending, coming across the base of the little finger, which is adduction, coming out from the palm opposition, and then first web space. So that's a range of motion assessment. Sensation, again, 2-point discrimination, testing that on both sides of the thumb, so radial and ulnar sensation. At 6 millimeters, 15 millimeters, and then working out whether it's complete sensory loss, partial, or actually no sensory loss. Level of amputation, he's kept his thumb, we've reconstructed it, so it's got a appropriate length. You could argue that it's got a fraction missing at the end. You could compare both sides. He might have, say, a 10% amputation loss. Second aspect to assess is the skin and scarring, which is Chapter 13, which is a combination of how does it affect his activity day living, and is any treatment required. So effect on ADLs, again, can be things like a hand function that's recognized as affecting his ADLs, ability to drive, sleeping. He might get pain in the thumb, which affects his sleep. Daily tasks like feeding himself, getting dressed, that sort of thing. But you wouldn't expect this guy to have many deficits. in terms of treatment required, he might need some moisturizer at most. Might have to wear a protective sleeve over the thumb at work or in the cold environment, but that's not going to be a lot either, I don't think. So he'll certainly fall into class 1 impairment, which is the lower end at about 0 to 9%, probably at the lower border of that, maybe 1 or 2%. Key point with plastics, as indicated, you often move tissue around from somewhere else. So in terms of your assessment, it's important to look at the donor side as well. In this guy's case, it's great toe. You're not going to measure the movements of that, but you're going to have a look at the scarring and any consequence from it. So that's part of the skin and scarring assessment with regards to the donor side. Before we finish off, key points that I guess have frustrations with in terms of what gets sent through for my assessment of patients is, for plastics in particular, photos are critical. You often get sent through scenarios of patients, and it's really hard without photos, and that can be to do with the injury, to do with the reconstruction itself. It makes my job a lot easier. Sometimes they're not available, so I get that, but if they're available, that would be great. Clinical records, it's surprising the number of patients who get sent through. Most do have operation notes, but a lot don't. And if there are multiple operations, sometimes only one is present rather than the rest of them. So it's, get sent through sometimes 1 to 2,000 pages of notes to go through. It's really tough to try and find the relevant sections, and I think the operation notes are critical, even if they could be put down at the start. The rest of the file with the other pages can be put in as well, but photos are critical, as are the operation notes. So in summary, complex hand injuries are very common. I deal with them a lot in terms of clinical reconstruction repair, and also from assessments point of view. As said at the start, I do other aspects as well with regards to hand injuries, scarring in different age groups, pediatric and adult, and other aspects of plastic surgery. Something that I really enjoy in terms of treating these patients, and I actually find these assessments they're pretty fascinating as well. There's a lot of measurements involved, talking to patients, and it's quite a lot of mathematical calculations, which I enjoy as well. So thank you for your time. Hopefully it's been useful, and I'll answer any questions that there might be.
Thank you, Dr. Thomas, for a very informative presentation. We actually have a couple of questions from the case managers who aren't able to make it today, as well as some in the chat box. So I'll go through them one by one. So first, is a hand harder to work on, given the skin is less elastic and thinner?
Well, in these instances, I'm not sure I'd say the skin is less elastic and thinner. The eyelid skin is actually the thinnest in the body. So skin has a degree of stretch to it. So even if you've got some skin missing, you can often pull it together. And if you look at yourself, there's, I think, reasonable amount of movement around the wrist and hand and forearm. Compare that to other parts of your body, such as lower leg, which are often very tight. Then generally the operating on skin around their hand and wrist and arm is, I wouldn't say it's easy, but reasonably straightforward, unless there's skin loss. If there's skin loss, that's a problem. And then you're looking at doing things like skin grafts or flaps. But in summary, the skin around the hand, wrist, and arm are actually pretty easy to work with.
Yep, thank you. So the next question is, in a degloving incident, what are the chances of a full recovery and use of the hands afterwards?
Thank you. So degloving, by definition, is where the outer layer of the tissue is pulled off, avulsed, or traumatized to the point where it may or may not be viable. So if you think about the term degloving, if you pull a glove off hand, which is essentially the skin, what's left behind, so that's tendons, nerves, arteries, and bone. So if it's a minor degloving, it may be a small portion of skin, and that might be able to be sutured back down and repaired, in which case that may survive, it may not. And then you get into more complex issues where the tissue is not alive and you have to resect it and take it back to healthy tissue. So those types of patients end up with skin grafts, flaps, bringing in healthier skin and tissue. And they can be pretty complex once you get into the flap side of things. So essentially any degloving injury, from a soft tissue point of view at least, tends to be on the severe side and more challenging, not something that myself and others don't deal with on a regular basis, but that doesn't end up being at the more difficult end of the spectrum.
Yep. Thank you for that. And for the last question, so someone asked if you could please give more insights to the crossover in relation to like major surgery that you mentioned in the slides. Like, do you work with other surgeons, like vascular surgeons, in those kinds of situations, or like orthopedic or?
Yeah, so different surgical specialties very commonly work with others, what are called combined cases. For myself, that would be a combination of orthopedics, vascular, general surgery, less so. And look, it depends on what level of injury. For example, if you had an injury at the level of the hand or wrist, then someone like myself, specialist hand surgeon, I would pretty much do all that myself, in terms of the bone work, tendons, nerves, and arteries. When you go further up the hand towards the forearm, elbow, shoulder area, that would almost always involve an orthopedic surgeon if there's a bone injury. If there's no bone injury, then generally the plastic surgeons would do the repair because there's no bone as such involved. So again, tendons, nerves, arteries, often repaired. Most plastic surgeons like myself are very capable of doing vascular repair. So you don't necessarily need a vascular surgeon there to assist, and I'd be very comfortable doing surgery with regards to repairing vessels, fingers, hands, wrists, forearm, even up towards the shoulder, but that does get a little bit of a grey area once you get up that high. So orthopedic surgeons, yes, more commonly. Vascular surgeons, yes, less commonly. Other surgical specialties, at least from a complex hand injury perspective, much less so, unless there's something else injured with the patient. Some patients have what's called a polytrauma or multiple sites of injury, chest, lung, abdomen, in which case they're getting operations from multiple different specialties at the same time. But for a hand, upper limb injury, it's especially hands by itself, essentially plastic surgery can do the whole lot.
Yep. Thank you, Dr. Thomas, for a very comprehensive answer. So if there are no more questions, I think that the presentation will end now. So thank you so much for doing this with us, Dr. Thomas.
Thank you for organising, Sophie, and hopefully everyone found things useful. And you know, there's a lot of these injuries out there that happen, and thereby there's a lot of medical legal work in this area.
Thank you. Thanks so much.
All right. Thanks, everyone. Thanks, Sophia.